Hello, everyone, and welcome to Taboo Topics and Parkinson's Disease. My name is Maggie Ivancic. I am the social worker and center coordinator with UNC's Movement Disorder Center, and we are coming to you to talk about conversations that are hard to talk about, that have some stigma, that are taboo. And today's topic is about genetics. So we are going to be hearing from Dr. Claudia Testa, who in this presentation has recorded her presentation and then will be with us live at the end. So we hope that you will listen and learn and use the chat feature to type in any questions that you may have throughout the presentation, and we will answer them to the best of our abilities at the end of the presentation when Dr. Claudia Testa will be with us live. So thank you again for being here today, and look forward to learning along with you.
I'm Claudia Testa. I'm a movement disorders neurologist and a scientist, as well as the head of our UNC Neurogenetics and Precision Medicine group. And then all these add up together along with genetic factors, or more specifically, genetic variation. So what does that mean? Genes, the DNA that make up genes, and the DNA and the big stretches in between genes is really variable person to person, and that's quite normal. A lot of that variability doesn't seem to make a big difference. It might be just redundancy or stretches of DNA. We don't completely understand what it does, but it seems to have this normal level of variability. For example, all of our finger pads or fingerprints are a little different, a little variable person to person or finger to finger, and it doesn't really seem to make a big functional difference. However, a lot of these changes, say maybe 10% of the population has one variant 30% as another variant at the same place in the same gene, and then the other 60% had some other variant. One of those variants might kind of nudge things towards a complex disease process like Parkinson's disease, or maybe nudge a little away from a complex disease process like Parkinson's disease. You stack up all these little nudges, all these little settings, a couple forward towards Parkinson's disease, one back away from Parkinson's disease, put them together with all these other external factors and choices, then add up to Parkinson's disease. Okay, so that does not sound very motivating for talking about genetics and genetic testing in Parkinson's disease. All these tiny little things that have to add up together, and we don't even completely know what they all are. However, there's really been quite a revolution in the last, say, 20 to 25 years that we're still trying to catch up with in terms of communicating to our patients, as well as to each other. That is that we know way more about genetic causes of Parkinson's disease. We no longer really think of Parkinson's disease as this idiopathic, giant unknown. Think of it as sporadic Parkinson's disease. Right now, that's most Parkinson's disease, so multifactorial, or there is a clear genetic cause, we just don't know it yet, and we call monogenetic Parkinson's disease. So monogenetic means one variant and one gene is the cause or the main cause. We used to think that this was going to be maybe less than 1% of people with Parkinson's disease, but now when you look across big cohorts, big groups of people, like the PD generation research cohort, which we'll talk more about, they're running at about a 10 to 15%. PD generation just reported 12% of their participants. They can find a clear-cut, monogenic, one change, one gene cause for that person's Parkinson's disease. That's more than 1 in 10. That's closer to 1 in 8. If you're math-oriented like I am, it might occur to you saying, yeah, it's, average 10 to 15% in big cohorts, but is that being driven by a little subpopulation where everybody else is mainly like 1% or less, and then these people are more like 40%? Kind of, not really. When you look at people with multiple affected family members, 3, 4, 5 people closely genetically related who all have Parkinson's disease, we can sometimes get the monogenic Parkinson's disease rate up to about 30%. But when we look at what we usually think of as regular sporadic Parkinson's disease, there's one person with Parkinson's disease in the family. Maybe there's like a second cousin 3 times removed, but really there's one person. They don't have anything unusual or unexpected about their journey with Parkinson's disease. At least 3 to 5% of these people, we can come up with a monogenic cause that we can detect now, that we know how to test for now. That's more like, maybe 1 in 30. That's still a lot more than we think of. When we ask people to estimate how many, 1 in what, 1 in 1,000, 1 in 100, 1 in a million, people don't usually say 1 in 8 or even 1 in 30. What do we mean by monogenic, one variant in one gene? There's autosomal dominant. This means that one of the 2 gene copies has a clear-cut cause or mutation that's causing Parkinson's disease. Autosomal recessive, we'll get more into autosomes later. That means both copies of the same gene both have that genetic change or mutation that's going to cause disease. And there are high-risk variants, like in the GBA gene. This is when these are present. This kind of variant is present in a person with clear-cut symptoms. It's likely to be having a very high impact, be a major driver of those symptoms. We used to throw around the terms mutation and variants kind of interchangeably. What we really mean is risk variants. These are things that are not expected to directly, completely cause a disease on their own. They combine forces with all those other little toggles, but instead of being a little bit of a nudge, they're more like a hard shove with their very high impact. Pathologic variants, or what we classically think of as mutations, is they're doing almost all the heavy lifting on their own in terms of causing disease, is a basic way to understand it. So now I've told you, okay, it's not 90% with a monogenic cause. It's more like 10 to 15%, in some cohorts more, but that means maybe at least 1 in 10, maybe 1 in 8 people with symptomatic Parkinson's disease right now, we can detect their genetic cause. So why genetic testing in Parkinson's disease? Always with genetic testing, we want to know, like, why are you doing it? What are your goals? And is the testing going to actually meet the goals, give you some kind of actionable information, something that you need? As a scientist, I love genetic testing because I love understanding things. And we have learned tons about Parkinson's disease for everybody from genetics. Many of you may have heard of the alpha-synuclein protein, which we think is really closely involved in Parkinson's disease pathology for everybody. We know about that protein because the very rare families that have monogenic cause Parkinson's disease, a variant or mutation in the SNCA gene that makes the alpha-synuclein protein. We didn't even know about that until we found those people with that monogenic cause of Parkinson's disease. With a genetic diagnosis, SNCA gene mutation form Parkinson's disease, for example, that's a confirmatory diagnosis. This is a step beyond the clinical diagnosis. This is saying this variant in this gene is driving Parkinson's disease for you. For a lot of people, there's a lot of power in knowledge. People often ask, like, how did this happen? Can you explain why I have Parkinson's disease? Where did this come from? They start searching for answers. For many people, having this clear-cut diagnostic answer can be really powerful. For other people, that's nice, but they're really more focused on the present and the future. How can they use this information? Is it of use beyond just the power of knowledge in and of itself? Really, we can give people more information about the present and the future now if we understand their monogenic cause of Parkinson's disease. This includes information about what we call prognosis. So we look at people who have the same kind of variant in the same gene and say, what's been reported? Are we worried about a higher frequency or earlier start for cognitive symptoms? We need to get ahead of that and make sure we're monitoring that, do everything we can to slow those down or prevent those. Or are we really not worried about that? We really haven't seen a lot of reporting about cognitive change in these people. And we haven't really seen a lot of reporting about autonomic dysfunction either. But wow, there seems to be an outsized amount of sleep disruption, say. So brains love sleep, so we definitely need to get more aggressive testing for that kind of symptom and getting ahead of it for the future. It's also a growing area of work trying to figure out what current treatments, how they can be better leveraged, maybe used or not used in particular forms of monogenic Parkinson's disease. This is why we style ourselves neurogenetics and precision medicine. We're trying to make individualized information about the benefits and risks of current treatments, depending upon what the exact genetic cause of the person's Parkinson's disease is. I'm really excited that the Parkinson's Center of Excellence here at UNC is really eager to try to get ahead of this growing area of knowledge, working with Dr. Roque and Dr. Krishna in the deep brain stimulation and focused ultrasound lesion surgery group to start folding diagnostic genetic testing in Parkinson's disease into the pre-deep brain stimulation workflow, not so we can determine for people whether or not they're going to end up with deep brain stimulation, but so we can say, here's some more individualized information for you about what to expect about benefits and risks, given this is your cause of Parkinson's disease, so that you can go forward with a decision that makes more individual sense for you. Already in the now, there are clinical trials, both to try to learn more about, in an organized way, the impact of genetic variants on current therapies like deep brain stimulation, but also looking at trying to develop new and experimental therapeutics specifically to help people who have very specific genetic forms of Parkinson's disease. So these are things that I pulled off of clinicaltrials.gov just as examples. These are all experiments. We don't know if these will work or not. So they are appropriately styled around safety, as well as trying to look at whether or not these agents will work. And I think we're going to see lots and lots more of these trials in the future. So really, this comes down to making informed life decisions. Really, we've been focusing on the person with Parkinson's disease. We'll talk more about at-risk people, what at-risk means in a bit. But we want to make informed decisions about understanding your own personal journey with Parkinson's disease. What can you do to clarify treatments and behaviors going forward? Do you want to consider research participation in clinical trials? And because it's genetics, how is this going to impact other people in your family? So before we kind of get to the other family members, let's stay focused on person with Parkinson's disease and genetic testing for symptomatic Parkinson's disease. There's three basic kinds: commercial or direct-to-consumer research testing and testing within clinical care. We're going to start with the commercial one. I'm going to continue to pretend that this cursor is visible on the recording. So in this first slide, there's a direct-to-consumer group called 23andMe. They make what they call the Parkinson's Disease Genetic Health Risk Report. They look at 2 genes. You might notice that the list of genes in the other columns are much longer than 2. They're looking at specific variants, not the entire DNA sequence, but specific variants just within these 2 genes. So they have a limited amount of information. They're only going to report back on specific variants within 2 genes. Upsides, direct to consumer means it all can happen at home. That can be a big advantage for people, and it's relatively inexpensive. It's not free, but it's not a gazillion dollars. I don't remember. I remember the last time I checked, it was under $100, but I can't remember if it was 25 or 50 or what it was. But it's relatively cost effective. What you get for that money is a limited number of variants in 2 genes, and you do not get professional interpretation of the results. We can talk about results interpretation a little bit. These are direct to consumer, so private company for-profit products, and that's not evil. It's just different from research. 23andMe has partnered with other entities to do research, but that's not what this risk report is. Research, it's not research and it's not clinical care. So it's under completely different regulatory rules and laws compared to research and clinical care. So there's outsized concerns about privacy, how information will be utilized and potentially monetized in the future. So moving to the middle ground, PD generation is one example of research testing. PD generation is an enormous worldwide effort that I'm now thrilled to say that UNC is part of. The PD generation group has chosen 7 out of the many possible. You can see an even bigger list over in the clinical testing. They've chosen 7 of many possible genes. They do look at the whole gene, all the possible variants, but there's still limited or potentially incomplete information that comes back. They're not looking at every single gene that could be involved with Parkinson's disease. Depending upon how the person is interacting with the research program to get their results back, they may not report uncertain or unclear results. But there are very big upsides because it's research and people are choosing in an informed consent way to join a research project. There's no cost. So there's no cost of the genetic testing itself. And there's also free genetic counseling. So you get free professional interpretation of your results and all your questions answered. At our site, Haley Segal is the genetic counselor who's doing that free post-test counseling. So those are tremendous benefits. I'm a huge promoter of PD generation. I would love to see tons of people enrolled at our site. One of the downsides of research testing is that because it's free to everybody, and they've chosen the right way to do this, very high data quality and free genetic counseling. It costs somebody money, and so they don't have the budget to offer it to every single person, say with Parkinson's in North Carolina. They currently open to everybody over 18 who has Parkinson's disease, but they have very strict limits on how many people we can enroll per month, because they have to be able to afford it on their research budget. We're hoping that they'll keep growing and growing their enrollment, and keep that expanded eligibility, but we'll see. Clinical care is over on the far side, and this is kind of what we're usually doing most often. There's a couple reasons for that, and there's also pros and cons. So as you can see, there's a really big list of genes. This slide is absolutely not an endorsement of any particular commercial clinical testing panel. We work with a bunch of different labs. Every clinic or academic institution has specific contracts with these labs. And so because we're a state institution, we have specific contracts with some of them and not with others. But certainly there are a bunch that aren't even on this slide: Athena, Fulgent, and others. These are our two most common contracts just with UNC. But there are others that are equally good. Also, it would have taken me 5 slides to put like every single gene and every single panel on here. I really just wanted to illustrate the concept that all of the clinical testing panels involve as many genes as they feel like they can stand. A panel is just a whole bunch of genes that they're going to test all at the same time. Most of the commercial labs like Invitae will have a core set, and then you can add on optionally more, and they'll give you set lists. And then the total cost is to look at all the variants in all the genes listed. You get 3 basic types of results. Absolutely nothing to see here. None of these things are causing a problem. Perhaps there's a genetic cause. We just don't know how to look for it, or we're not looking for it with this particular panel. Absolutely pathogenic. This is definitely a problem and is very, very, very likely to be the cause of Parkinson's in this individual. And everybody's favorite result is the dreaded variant of uncertain significance, or VUS. The uncertain result means there's a variant there, but we're not really sure. Is it a fingerprint variant, or is it really troublesome? So then that just means that I and the genetic counselors have more work to do to see if we can gather more data that really pulls that uncertainty over into the definite no, or over into the definite yes category. It's sort of an upside and a downside at the same time. The more genes you look at, the more likely you are to come up with an uncertain result and then have more thinking to do. You certainly have more to explain to people about what the range of results are. The clinical testing is very strict confidentiality rules, but it is not free. This will either run through insurance. We have fairly good luck getting diagnostic testing covered by insurance. I know that the UNC financial aid health insurance, for example, 100% covers diagnostic genetic testing. But some insurances don't, or have an out-of-pocket copay. The commercial labs will work directly with people on, okay, we're going to run it through your insurance. If it's over, say, $100, we'll give you a call, and then you can decide if you want us to pull it or go ahead and send it. You really are trying to de-risk it in terms of the finances. The ultimate de-risking is to just say you're just going to self-pay it. You're just going to not deal with insurance. You're just going to pay it and not worry about it. Right now, the average cost for doing an entire clinical panel for Parkinson's disease diagnostic testing is about $250. I know often people are really shocked when they hear that number because they think it's going to be closer to $5,000. So it's more expensive than 23andMe, and it's certainly more expensive than research because it's not free. But really, we're running anywhere between $0 and $250 for cost for this kind of testing. So usually this is a place in clinic where I've been burbling along really excitedly because, and people noticing people's eyes are starting to glaze over because I'm so excited to be talking about genetic testing with people, but I am a physician and a scientist, and I am not a counselor. Like by my personal data-free estimate of roughly 99.9% of physicians not trained in counseling. So this is where people like Haley Segal usually come in. Genetic counselors are specifically trained in medical genetics and also in counseling. If I suddenly became, I don't know, Queen of the Galaxy, somewhere on my giant priority list would be that not only everybody with Parkinson's disease has an opportunity to do their diagnostic genetic testing, but they get to talk to an awesome genetic counselor. So the genetic counselor is going to use that medical genetics training combined with their counselor role to really empower individuals to make informed decisions about genetic testing, to understand the whole process, to get voluntary informed consent, to understand the risk, benefits, and limitations of genetic testing, and have a conversation about goals and readiness. Again, what's the goal? And is doing this testing actually going to meet that goal for the patient or not so much? Are we picking the appropriate genetic testing? Should we be doing one of these panels? Should we be doing a microarray or something else completely? And to really meet a patient and family where they are, people have very wide-ranging different levels of understanding of genetics and genetic testing. We want to make sure people are understanding what's going on with them, getting their own questions answered to their satisfaction, and then being set up for success. For example, explaining, okay, this is why we recommend this particular choice for genetic testing. These are the possible results to come out of it. Let's set you up so that when you get your results back, then we have a conversation how to interpret them. You're already kind of primed for that. You're going to really get into the medical information. For example, if we find a monogenic cause, we're going to get into disease management options, medical implications of that, how to hook up with clinical trials, but they're also going to get into psychosocial implications. They're going to talk about supports, whether that's external support groups or support within that patient's own family and friend cohort, and talk about how to cope with outcomes. How are you going to think about this big emotional reaction that you didn't predict you were going to have when you got a negative result? How are you going to cope with the pros and cons of transmitting this personal medical information outwards to other people? And what are your choices around that? And what kind of support do you need for that? So when people come to us thinking about genetic testing for Parkinson's disease, sometimes they'll see me and a genetic counselor. This is in a shared visit booked under my schedule. That's because maybe they or their referring doctor isn't so sure it's Parkinson's disease. They want like a closer look at what's going on so we can get the neurology information in there along with the genetics information to make a good choice for testing. Sometimes it's just because there's not a lot of clinical information, and it's really helpful to have like a movement disorders exam and more of the clinical information so that we can interpret the genetic test results for people in a way that makes more sense for them. But most of the time, people are just blown right by me, going straight to the genetic counselors. Genetic counselors, independent healthcare providers, fully trained, can order genetic testing themselves, and who work directly with people. And really, they're all about autonomy, respect, and meeting people where they are so that we're going forward with testing or choosing not to go forward with testing in a way that's informed, is making a decision that works for you. And then we get testing results back, you're able to engage with them and deal with them and have support doing that. So while this emphasis on genetic counselors, I think they're awesome, and I have decades of experience to back that up. But I think particularly in Parkinson's disease, their role is really critical because genetics in Parkinson's disease gets complicated. And a lot of things hold people back from engaging with genetic testing. And that's why this is in this taboo topic series. So just looking at my timer, the big thing with genetics is that it can really get into identity, race, ethnicity. The genetic counselors and I are going to go there when we talk with people, because it's really important to be able to engage in a respectful and open way about things that have a direct medical impact on what kind of genetic testing are we going to look at, how are we going to interpret it, how are we going to talk to you about what we think the yield is going to be. One of the upfront things that this does is that people just come in with this assumption of this testing is not for me because it's for other people. I've heard that it's for younger people. I've heard it's for Jewish people. I've heard it's for people who are just not like me because I'm not one of these high yield test results. So where is this coming from? Remember, I said maybe that 10 to 15%, kind of roughly 1 in 8 of people we can find a specific genetic cause for their Parkinson's disease right now. That percentage goes up when there's a whole bunch of people, 3, 4, 5 closely genetically related people in the same family with Parkinson's disease. That chance, that 1 in whatever, tends to go up the earlier the patient's symptoms are. Also, there are some subpopulations who have a very high rate of carrying these high risk variants, these variants that are a little closer to a strong push than a nudge. Classic example is the Ashkenazim Jewish population. There's a relatively high rate of people who carry a high risk GBA gene variant, high risk for Parkinson's disease. So, however, we super don't know everything about genetics and Parkinson's disease. And the more we look, the more genetic causes of Parkinson's disease we can find and identify and talk about. So just about a couple months ago, there was a big discovery, a collaborative effort between the GP2 research group, Black PD, BLAAC PD, and PD Generation to look at new high-risk Parkinson's disease high-risk variants in the GBA genes. And they identified one in people of African descent, a group that we really haven't been talking to as potentially at high risk for having something that could be driving Parkinson's disease in them. So the more we look, the more we find, and the more we think of this as for everybody. But I've already talked about Ashkenazim Jewish heritage, white versus non-white populations, self-identified within the US. This is stuff that as a culture, we're pretty uncomfortable talking about. We're not awesome at it. I know I'm not. And it takes a lot of effort and learning to address people, whether they're white or not, whether they have a specific ethnic or religious family identity or not. And to get into that information, I think there's a lot of fear. People have had negative experiences around these identities and information. There's fear about how that information might be used because of what it is. But really, I think fundamentally, props to the very clever 23andMe team. 23andMe really captures the essence of genetic information. It's not just medical information or research information, but identity information. Unless you're my close friend and colleague who's a stroke neurologist, you probably don't have a very strong identity relationship with your cholesterol level testing. Really. But in contrast, there are entire television shows, podcasts, ancestry websites that really lean hard into genetic information as identity information. And why is that? It's because it's really fundamentally about your genetic family, not your found family, not the family you interact with in real life, but your genetic family. So often people say, what am I going to tell my family? Am I going to tell them about this personal medical information? Sometimes there's a lot of fear, even though it's something that you can't change, that you never changed, that you never affected yourself. Born this way, but yet there's still this, in many people, they tell me about this big sense of guilt and this fear about what kind of reactions their family members are going to have to information about monogenic Parkinson's disease in their family. There's also circumstances where people come to us and say, well, this is fascinating. I'm feeling this big moral and ethical obligation to interact with people, but these are people in my genetic family that I said bye-bye to a long time ago for really good reasons. And I am not thrilled at the idea of reconnecting with them for any reason. However, now what? So what are we going to tell families? The information for the family really depends on the specific genetic test result. So look at my timer again. The connections between the genetic status of the person, so do they carry a genetic variant, and the risk of developing Parkinson's disease are a bit complicated. So let's take the easiest case. So autosomal dominant, autosomal recessive. Right now, all of the major genes involved with Parkinson's disease that we're aware of are on chromosomes that we call autosomes. So there's the genetic sex chromosomes, the X's and the Y's, and then there's everybody else. For the autosomes, you get everybody has 2 copies of these genes, one on each of the 2 chromosomes. And that means that everybody's genetic kits, genetic offspring, are 50-50 of getting a copy that has a variant that causes Parkinson's disease, in this case, the big red P, or the copy that is just fine. There's a variant that has nothing to do with Parkinson's disease, the little p. So in this family, this is an autosomal dominant change. One of the many genes where changes work this way is the SNCA gene. This is the gene that makes the alpha-synuclein protein. So the people in the filled-in boxes, filled-in shapes, I should say, are people with Parkinson's disease. You'll notice that everybody with a filled-in shape with Parkinson's disease has the large red P. They have one copy of this Parkinson's disease-related gene that has a variant that causes Parkinson's disease. And if they have that one copy, that one variant, that one gene, then they have Parkinson's disease. Each person has a 50-50 chance of inheriting the big red P or inheriting the little bitty p copy. So real families rarely work this cleanly. Each individual has that 50-50 chance getting the large P or the small p. Everybody who got the small p from both genetic parents is not going to get Parkinson's disease. Others in it's not going to get Parkinson's disease. So this is a relatively easy inheritance pattern to explain to people, and it's a relatively easy risk to explain to people. Autosomal recessive gets a little more complicated. The dots are people who are carriers with Parkinson and instead of P for the autosomal recessive. So a carrier is somebody who has a variant in a gene, like the Parkin gene, that can cause Parkinson's disease, but you need to have both copies. Both copies of the gene have to have the Parkinson's disease causing mutation. So you have to have mutation in both of the copies. So you have to inherit one from each genetic parent. So if you're doing the math, that's 50% chance from one parent, 50% chance from the other genetic parent. That makes a 25% chance of getting both copies have a mutation that causes Parkinson's disease. You also have a 25% chance of getting both the little n's, the copies that do not have a mutation on them. Everybody with 2 little n's is not a carrier. All their descendants don't have to worry about the land of Parkinson's disease. But everybody who is a carrier, who gets one copy with a disease-causing mutation, if they get together with another carrier, then their descendants have a distinct risk of developing Parkinson's disease. So there's a lot more information to convey to families, and a lot more to tell them about their own genetic status, or also what they want to think about in their genetic partners. Finally, there's the autosomal dominant. So that means one copy of this gene has a variant in it that's enough to cause Parkinson's disease. But these are now pink and orange instead of red, because in some genes, this gets complicated by what we call reduced penetrance. So penetrance means if you have that copy, say the big red P that has a disease-causing mutation for this family, this fake family, this is 100% penetrant. Every single person that has one copy of the gene with the mutation develops Parkinson's disease, period, the end. In this fake family, the percentage is lower. So penetrance means you line up 100 people, they all have one copy of the gene with a disease-causing variant. How many of them get the disease? 100, that's 100% penetrant. 60, that's 60% penetrant. 30, that's 30% penetrant. So you notice that there are people here who inherited that big orange P, the one with the disease-causing mutation, but don't have Parkinson's disease. Variable expressivity means that people get Parkinson's disease, or at least some symptoms, but it's milder or different. It doesn't look like Parkinson's disease. Those are the people, the shapes that are partially filled in. So now what you're explaining to this person, the original person who's clearly symptomatic, gets their genetic testing result, that's a pretty clean explanation for them. But then what do they tell the family? Well, you have a 50-50 chance of having Parkinson's disease, or inheriting this variant but not getting Parkinson's disease, or inheriting this variant but having some other experience. And then how it tracks with the family can look very different. So this kind of gets into making informed decisions, not just for the people with Parkinson's disease, but for people who are at risk as well. So what does at risk mean? Adults who are at risk of carrying a gene variant that can cause Parkinson's disease. So in these made-up pedigrees, so it's everybody in the generation down from the original people. All these people are 50-50 at risk for inheriting this P. They're at 50-50 risk for inheriting this orange P. That doesn't mean they're at 50-50 risk for getting Parkinson's disease. They're at 50-50 risk for inheriting this disease-causing mutation. So that is not a straightforward conversation, but this is often what happens. A non-symptomatic adult comes in and says, hey, I'm the family. Remember me? I was in the room with my parent a month ago with you, and you were going da, 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 about genetic testing. My brain was going, I have a lot of questions for you. These people generally actually blow right by me and straight to the genetic counselors, because this is really what they do best. Predictive testing means an adult in our society that's greater than 18 years old, who has a close genetic relative with a monogenic Parkinson's disease, so at risk of inheriting a disease-causing mutation. And they are wondering if they want to know their own genetic status. So again, this becomes a discussion of wants and goals. Is going forward with genetic testing actually going to meet the person's goals and give them what they want, or really not so much? People will explore through rationales and motivations with a genetic counselor, not so much so the genetic counselor should tell them what their rationale should be, but more because sometimes people are like, wait, I don't know, I haven't thought about that. And then when they think about it, they start exploring whether they really want to go forward or not. They might make a decision that was different than what they had originally assumed their decision would be. We're very open to the idea that people are going to have reactions that are different from what our own personal reactions would be or might seem unexpected, whether that reaction is negative or positive to different kinds of results. We'll just support people for preparing for the future. Genetic counseling will go through the legal ramifications of doing predictive testing in a non-symptomatic result, which are different from doing diagnostic testing. There's a federal law because of Genetic Information Non-Discrimination Act, or GINA, which protects people's in the workplace and people's health insurance, but does not necessarily protect life insurance, long-term care insurance, and some other things. So going through that's important. So again, make an informed decision about things you might want to put in place before going through testing, or whether or not you're even going to go through testing. And then again, who else in the family is going to be affected by your decision to go through with your own testing? Are you going to keep that decision to do testing private? Are you going to keep the results private? Or is it better for you personally and your family for you to communicate? How are you going to do that? And are you going to need support? So hopefully I have convinced you all that you would love to learn more about genetic testing and Parkinson's disease. We are recruiting for PD generation, and we love talking to people about research. So hi, research team, please contact me. Just let Maggie know your preferred method of contact, and the team will definitely talk to you. Talking to the research team does not mean that you are necessarily agreeing to participate in research, whether that's a PD generation or something else. We would love an opportunity to at least talk to you. We're not perfect, and we want a chance to speak to people. I'm just going to put it out there. PD generation is definitely for everybody, and we're not going to block anybody, no matter who they are, from participating. But we as a community have been pretty bad at talking to people of color, answering their questions, and having them feel secure and happy about going forward with participating in research. PD generation overall is running about an 80% white participation. And that's not necessarily bad. It is for everyone, but it just means that we as researchers have got to do a better job reaching out to those communities who so far have not felt comfortable with participating. Also for everybody, just like PD generation, is clinical genetic testing. So if you want to consider diagnostic or at-risk genetic testing, and you can come physically to Chapel Hill, or you can do a telehealth video visit from a home in North Carolina. Them's the rules. I don't write the laws. That's just how it works right now, though we're exploring ways to kind of jump boundaries, especially with genetic counselors that are legal. Then just make us a referral. We do have an agreement with the Party Neurology Clinic outside of Asheville. Their general neurology UNC affiliated practice. We can cut deals for people to go physically there if it's truly too burdensome to come to Chapel Hill, and there's no way to do telehealth video at home. We'll find a way. We'll refer you to somebody else that's closer to home. We'll make it happen. But the place to start is to have your friendly local primary care or general neurologist, or anybody really, make a referral to UNC Genetics, which is a part of UNC Neurology, Genetics. Maggie says she can get this web link to you or your referring provider if you'd like. And if you guys have any questions, Maggie and the UNC Neurogenetics team can help. I personally, along with genetic counselors like Haley, go through all of the referrals so that we're doing our best to make a good match for the kind of appointment and the type of provider that people are seeing. Here's Maggie's information. And I am mortified that I don't have Haley's information on here. I have a pause button. Let's see if I can figure out how to use it in time. No. Okay. I'm going to stop sharing, and I'm just going to give Maggie Haley Segal's contact information and email if you want to communicate directly with the UNC Neurogenetics team. All right. See you all in real time shortly.
Wonderful. Hi, Dr. Testa. Thank you for being with us today. What a smooth transition that was.
Even wore the same outfit just to confuse people.
Well, thank you so much for that presentation and for being with us here this afternoon. We have already got some awesome people asking some questions in the chat. And I will definitely get Haley's information. And when we send the details out about this afterwards, we will make sure that people get that. But thank you so much for taking the time.
Yeah, and so in full disclosure, just in case I got questions about general genetic counselor stuff, I kidnapped Jenna Leah, who's behind me. She's, we should have made her like a little Haley face on a stick. She's playing Haley right now, and Haley is working with ALS patients right now. So Jenna's going to keep me on track if any of the questions are really weighted towards genetic counseling.
Awesome. So we've got the best of both worlds with this. That's great. I will start with this first question. So among early age Parkinson's disease, 30s, 40s age group, does this group have a high prevalence of a specific mutation, maybe around 50%? So if you have a cross-section of PD patients and it includes some of these young diagnosed PD patients, then this will pull up the percentage among the whole cohort. So isn't it important to talk about age groupings when talking about the prevalence of specific mutations in PD cohort? I've read that later age diagnosed patients have a much lower prevalence of PD related mutations. Is that true?
Yeah, so that's all true. So I don't know of anything that's super high, like 50, 60% in any age onset group. I think there's a couple of things that make it challenging to interpret the age of onset data against how likely it'll be that somebody has a genetic cause of Parkinson's disease. So for the very early onset people, this tends to be more the autosomal recessive things. So these are the ones where you have to get a genetic change, variant, or mutation from both genetic parents and not just one. So they definitely seem to be a little more heavily weighted towards the autosomal recessive ones, so a gaggle of uncommon things. But that's just running the odds. We certainly see some of the other genetic causes, the autosomal dominant genetic causes causing very early onset. But some of the most common, as far as we can tell, genetic causes for Parkinson's disease, like the variants in the GBA gene and the LRRK2 gene variants, have a relatively high proportion of people with regular sort of medium or even late onset for their motor symptoms. So it is definitely true that there's a higher rate of monogenic Parkinson's disease in people with very early onset. The numbers I've seen for specific research cohorts are a bit all over the map in terms of, is that rate 30% or 35% or 20%, you know, they're just definitely going to be higher. And then similarly, the rates are a little bit all over the map for the cohorts of people who have relatively late or kind of medium onset. Those tend to be more in kind of the 5% range for people with clear cut that we know how to predict now, that we know how to detect now, genetic cause. But you know, we used to not know that LRRK2 was out there, and we used to not know that the GBA variants were out there. So some of those numbers are from when we didn't know about some of the things that are more closely tied to late onset. So if you're a numbers person and you're really not very motivated to do things unless you can get that predicted percentage pretty high up, or if you're a Bayesian like I am, then you're going to use your, you know, prior information to make your decisions. So yes, if you have a later onset and you have really no clear family history, and you're not in a self-reported ethnic or ancestral group that seems to have a high rate of something, then a rough guess is that it's probably 5-ish%, maybe a little less, that will pick up a genetic cause for Parkinson's disease that we know how to detect now. For some people, more than 0 is enough, right? And for other people, they're just not interested unless it's a much bigger predicted percent. And either way is okay.
And is that when a genetic counselor's advice would kind of come into play, or is that something that people would think about before? And I'm curious.
Yeah, so I think in Parkinson's disease, for diagnostic testing, I think we use a lot more what we call pre-test visits with the genetic counselors, just because it can be a lot to parse. People have a lot of very reasonable questions, like, okay, my age of onset is this, and blah, 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 what can you tell me about these things? And I think these are all extremely reasonable questions for people to decide to go forward with stuff. What's insurance covered keeps changing, costs change, and what the downstream consequences of different results are keep changing. So it's different from some other genetic disorders where there's really like one gene with one change that causes one thing. And so then we have a lot more like upfront standard information that's the same for everybody, and kind of takes a little less parsing. In those cases, we see a lot less use of the genetic counselors upfront.
Okay. Another question that we have is, are you familiar with the genetic testing that is done from the Michael J. Fox? Because this person said they're not sure if they were tested for genetic abnormality or not. With that.
Right. So there was, I might not have all of the details memorized off the cuff, but a while ago there was an effort that was a partnership with Michael J. Fox Foundation, 23andMe, and some other entities. I think they only looked at GBA and LRRK2 and used the 23andMe panel, kind of leveraged that. That's what I meant in the talk when I said that 23andMe does do some research sometimes, but their commercial product is not research. I don't think that study is still going on. I think that both the Michael J. Fox Foundation funding for genetic research and overall sort of efforts towards research genetic testing are really focused on the PD generation study, because it's more genes and more sites, sort of more access for more people. So if you ever actually participated in a research study, hopefully you have a consent form or you have an idea what happened. And you can always call the contacts on that to say, hey, I need a reminder, like what exact information of mine do you have and how much of it do I get back? That's never cheating.
Yeah, that's a great idea. Another question related to that is, if positive or negative for abnormal genes, is this person right that there is a misfolding of alpha-synuclein?
Ooh, that's a really interesting question. So it's kind of yes and no, both things. So the as I think I remember to mention the talk, there was a couple, literally 2 families that people figured out the initial mutations. I think there were duplications and triplications in the SNCA gene, which makes the alpha-synuclein protein. And then people were like, oh, that's weird. And so then they went looking for alpha-synuclein protein people with Parkinson's disease who did not have problems with the SNCA gene. And so then that led to thinking of Parkinson's disease as what we call a synucleinopathy. So misfolded or messed up or clumped together or misbehaving alpha-synuclein protein seems to be a big problem in Parkinson's disease, in this Parkinsonism called multisystem atrophy, and in a couple other hyper rare things. However, weirdly, as we learn more about some of the other genetic causes of Parkinson's disease, some of those seem to have no problems that we can find with alpha-synuclein, although they look on the outside exactly like everybody else with Parkinson's disease and respond to all the same interventions. And so that's one of the reasons that the clinical trials are moving towards looking at things that might specifically work for people with those genetic forms of Parkinson's disease, especially LRRK2, because a lot of people with those genetic forms of Parkinson's disease don't seem to have a big problem with alpha-synuclein, which is very weird.
Yes and no. Yeah, interesting. A person who is autosomal recessive genetic status, do they have a less progressive disease?
Very much depends on the exact genetics. So some of those on average tend to be early onset and slow progressing. But we have seen cases that just have a specific kind of mutation that seems to be more severe. So it very much depends on the exact genetic variant or the exact mutations that are involved.
I feel like you that's the answer to a lot of questions. It just depends.
I mean, it's really one of the things that's the reason that geneticists who do any kind of medical care have started styling themselves as precision medicine, is that it is very different person to person, the exact kind of genetic variant, where it is in the gene, what kind of change it is, makes a huge difference. And so there's a lot more variability and a lot more kind of individualization of us trying to explain to people what we think is going on, and the range of symptoms and experiences people can have, even though the gene name is the same.
Those are the questions that are currently in the chat. I'm just going to check one more time through to make sure I don't see any else that have come through. But I was wondering, since we didn't get the perspective, or you did an amazing job of telling the perspective of the genetic counselor. I was curious if the genetic counselor would like to share a little bit about the things you commonly hear from patients or families that would be helpful for people who are interested in this to know.
So I think just mainly Jenna. So Jenna usually works with my Huntington's disease patients, dystonia, and a lot of pediatrics patients. Yeah. So she's standing in as I am a genetic counselor.
Yes,
so as opposed to what I usually tell Parkinson's patients, when you have somebody who comes in, if they have a disorder like Huntington's or Parkinson's disease, what kinds of stuff do you like to be sure you discuss with them?
Yeah, I think that a lot of the times that you guys have already touched on some of the major conversations. So we will talk about what's the likelihood that we can find a change that is explaining the reason for the symptoms. Also saying if we were to find a change, what are the different types of results we can get? I think everyone has familiarity with variants of uncertain significance. So certainly planting seeds at the front ends that we may get a result, but we might not still get an answer at that point. So being really transparent about how genetics sometimes can feel like a yes and no, but a lot of the times it's this weird in between. And then ultimately also just talking about that variability you guys discussed, as well as if we get an answer and we get a gene, that's just one piece of the puzzle. Our genetics is of course a big contributor in a lot of ways, but ultimately the person sitting in front of you should guide what we're talking about. And if we're reading one thing and seeing something else, that doesn't happen to mean that one is wrong or the other is correct. We just need to take it more as a holistic picture to have an idea of how that gene may be acting in that person and how that the reason why it may look different from person to person. So I think really just kind of hitting those, what are your expectations for genetic testing? A lot of times people think of it as like any other blood draw that you're going to get a value for, and it's going to be high or it's going to be low, and that's just not the case with testing. So I think that that's a really big part of it, but also just validating that it's confusing not to have an answer, and it's hard not to have an answer, but no information is still information in a way of that. If we're going to try to do it for the purpose of them knowing the why or being able to provide information to kids, we're doing everything that we can at this point, and genetics is constantly changing. There may be options in the future, and they're in the right place at the right time for us to start those conversations.
Thank you so much for speaking off the cuff about this, because I think that's so important, that you like may get a result, but you may not get an answer. You're not going to get that. You may not get that quantitative, concrete yes or no that you were expecting. Thank you. That was great. And we got a couple questions while you were talking. So this person says that they have not had genetic testing, but they're not aware of any other family members with Parkinson's, but they have been exposed to chemical burn emissions. And is that something that can bring on symptoms? Maybe it's not a genetic, maybe it's something else.
So we do know of some clear environmental exposures. I think the most famous might be a contaminated batch of heroin that caused a rapid onset Parkinson disease in the 1970s in San Francisco, and really led to us understanding the role of mitochondria and mitochondria energy in Parkinson disease. So there are a couple of really clear-cut things here in North Carolina. A lot of our farmers were exposed to very high levels of paraquat and as a pesticide, and may not have had the access to the proper protective equipment to be using. But for the most part, we have a pretty poor understanding of what all the environmental factors are and what all the environmental exposures are that might be involved with Parkinson's disease. We know they're out there, but we certainly don't know the whole list. And sometimes that can be challenging because it's hard to test for, it's even hard to like make a case that we can make a straight up yes and no about anybody's specific environmental exposure. The fact that somebody's had an environmental exposure that may or may not be involved in Parkinson's disease doesn't mean that they don't have a genetic cause. With a genetic cause, plus environmental exposure, maybe your symptoms are a little different, maybe your age of onset is a little earlier than it would have been if you didn't have the environmental exposure. It's kind of hard to go back in time. Because there's new understanding of how different interventions like deep brain stimulation might impact people, because there's new understanding of things like, in some of these cases, synuclein is not a thing. Because of the new clinical trials, we're really starting to recommend considering clinical diagnostic testing for everybody, no matter what their family history, exposure history, unless it's just a very small number of people with very clear individual exposures. But generally speaking, no matter what their exposure history, family history, or age of onset, because there's more now. So if you're one of the 3% or 5% that we're kind of like, wow, that's a surprise, that might still, in the now or in the near future, really change quite a bit of what we're going to try to do. I did see somebody ask if we're doing research with alpha-synuclein antibody studies, not that I'm aware of here, but I'm going to kick that one back to Maggie, because it's part of her job to help people connect by using tools like Michael J. Fox Trial Finder or clinicaltrials.gov with anywhere in the region. We definitely partner with everybody we can who's doing clinical trials to get people hooked up. But if you say had LRRK2 gene variant driving your Parkinson's disease, they would probably discourage you from joining that trial because it may not help at all for that particular form of Parkinson's disease. So we're finding that we're using this information more and more, although I will acknowledge, just like both of those questions, both the earlier question and that one implied, that for some populations of people with Parkinson's disease, the likelihood of us finding a genetic cause is much lower than in others.
Yeah, and when as relates to studies, and if UNC is not doing any studies on antibodies for alpha-synuclein right now, but to find out who is, go to clinicaltrials.gov, and you're able to search for Parkinson's disease, the disease, and see what studies are currently enrolling people, and you can see exactly what they're looking for, and look for eligibility requirements, because that's what you need to know if you're going to be eligible for the study or not. But clinicaltrials.gov, that is where every trial that is going to be recruiting people for study will be posted. So definitely keep an eye out on that website if you are interested in joining a clinical trial or just looking to see what people are doing right now and who's being recruited.
You can also put a second keyword in, so always put Parkinson's disease, but you can put a keyword alpha-synuclein in, for example, if you want to narrow it down.
Yes, yes. And this question, the last question we have was, are you aware of any genetic defect which exists in ALS and PD? I don't know if that means together or.
Yeah, so I am not aware of the genes that are involved in Parkinson's disease being clearly involved in ALS or motor neuron disease, no name for that. There are some overlaps with Parkinsonisms and motor neuron disease a little bit. There's one thing, a gene called C9orf72 that seems to be a problem in some Parkinsonisms sometimes. And it's also a player in ALS genetics. So I definitely have people, if there's any question about, I'm not sure if this is Parkinson's disease or I have a complicated family history, then we usually try to get people in to see both me and a genetic counselor in a shared physician genetic counselor visit as opposed to genetic counselor visit, because I'm going to want to take a hard look at the movement disorders exam to see if we're dealing with Parkinson's disease or a Parkinsonism or something that's a little different, and to see if it makes sense to tie it together, or if we're going to tell somebody what we told them recently, which is you've got one family member with ALS, you've got no family members with Parkinson's disease. We think that this testing is straight up focused on Parkinson's disease. We don't think that these two things are related genetically in your family. It helps us figure out what kind of testing, because we might say, oh, this is a little unusual. We might want to run a different panel or put together a specific panel or add a couple of things to the regular Parkinson's disease panel that sort of covers more bases. So the basic answer is no, those two genetics are usually two separate things. But if we have a question like that, then we'll kind of dig a little deeper to make sure that we're covering all our bases, and for that individual, that those two things are really true, and unrelated.
Thank you. I think that kind of sets us up for a good wrap up if there are no other questions, because if someone is interested in getting diagnostic testing or PD generation, I know you said at the end, but I'd like to say it again before we conclude. They can get in touch with me, or they can get in touch with the clinic and ask for UNC Neurogenetics, correct? Okay. So yes, if you're interested in genetic testing, please reach out. We'll be happy to get you connected with our UNC Neurogenetics team and their genetic counselors so that you can make the best informed decision for you and for your family. I would
also just, Maggie, to jump in there and emphasize, because I know I talked about this at the end of the pre-recorded thing. We didn't really get much questions on it, but if you have adult family members, like adult kids or an adult sibling who is wondering about, are they at risk for genetic Parkinson's disease, or you have somebody in your family who has a diagnosis of genetic Parkinson's disease, and there are people both symptomatic but also at risk, not symptomatic, who want to talk. This is where I think the counselors really excel in explaining things and helping people decide on informed decisions. So our team is for people with symptoms for diagnosis, but also for people without symptoms who are trying to figure out what they want to know about their own genes and genetic status.
Thank you. Super important. I hope that everyone will join us for our next webinar, which will be happening November 17th. We will be talking about the taboo topic of death and dying. Dawn Kelsey is going to be with us sharing about that from Transitions Life Care. And she'll be sharing about what does it mean to have a good death and what supports are available at end of life. We'll be bringing that conversation to you next month, November 17th at 1 o'clock. So thank you, everyone. Thank you for joining us today, and we'll see you in a month. Take care.